Hello, everyone. Thank you so much for joining me in this episode of Medical Research with me. Today, the topic I have chosen for discussion is clinical audit because this is one of the less talked about topic among clinicians, and I thought it is relevant. Let me start with a quotation, as always, with Dr. Hugh Brendan Devlin. He was the director of surgical epidemiology in England. Surgery without audit is like playing cricket without keeping the score. You can imagine if you cannot see the score, if somebody is only playing in the cricket, it becomes boring. And same thing is applied in clinical setting too. So these are the learning objectives of my presentation today. First, we'll define what an audit is. Second, we'll discuss about the importance of it. Third, we'll go through the steps. And finally, we'll then describe the basic differences between research and audit and some controversy surrounding it. So how we define audit? This is the most comprehensive definition given by NICE back in 2002. It is a quality improvement process that seeks to improve patient care through systematic review of care against explicit criteria. All the words which are underlined here have strong meaning. So there are four groups of words that are underlined. So the audit has four components. It is a quality improvement process. The idea is to improve patient care, and how it is done by a systematic review of care, and how or who do you compare with it. There are standard explicit criteria against which you compare the performance. And this is done basically to assess whether current performance of care meets existing standard or not. And one thing we have to note is the fact that standards of care change with time. At one time, open cholecystectomy was the standard of care. Nowadays, laparoscopic cholecystectomy is the standard of care. So one clinician should be up to date with the current standard, then only he or she can perform audit. So let's talk about the explicit criteria. This is one of the most important expression in the definition. So we should know what explicit criteria are. The first one is about the structure, second is about the process, and third about the outcome. So what are the things we look at in the structure part? So basically, structures means what is in place. For example, how many people are there in the program, how many faculty there, how many residents are there, and how far they have reached in their training, and how knowledgeable they are, and the way they are led and function, how much pay are they getting, are they, are satisfied with the job. This is regarding the people. And how about if it is a surgical specialty, do they have good OR facility? Do they have necessary equipment to perform uh, a surgery with acceptable standard? That comes under, and many more things you can think about regarding the structure. And regarding the process is basically what you do when the patient comes to you. The examples would be how referrals are processed, what diagnostic tests are performed in a patient, whether you are doing over ordering the test or under ordering the test. What is your transfusion blood transfusion policy in your institute or your policy? What is the status of regular care in the ER, OR, ICU, ward, etc.? And what are your discharge and appointment policy, or how are you planning to get and see the patient back in the OPD? All these things are regarding the process. And regarding the outcome, outcome basically means what you may measure regarding the patient care, and the most of the metrics that are related to the outcome are these. For example, mortality. In your care, how many patients die with a given disease? What is your rate of wound infection? What is your rate of resurgery and readmission, return to work, length of ICU or hospital stay? All these things are the metrics by which you measure the outcome of your care. So these are three expertise criteria should be remembered, and if there are any deficit here, we can always work on correcting them. If the care falls short of the criteria chosen, the change in the way care is delivered is imperative. This is an obvious statement, but doesn't happen always. Now let's go briefly to, now we have decided we would like to do an audit. So these are the steps you should do. First, you should select a topic. For example, if you perform surgery and for last 1 or 2 months, you seem to have more, you have detected more post-operative wound infection, then maybe you'd like to do the wound infection. And next is defining the purpose. What is the purpose of doing the audit? Because you think that your wound infection rate seems higher than the currently expected wound infection rate. And third is you need to do a planning. So the planning actual audit is performed this way. So this is called audit cycle. It has got multiple steps, total 6 steps here. I will go briefly one by one. First thing is you identify the problem. For example, just in the previous slide, I discussed that post-operative wound infection could be a problem that we have identified. Next is, now we need to agree upon the criteria and set standards. So we need to review the literature, find out what is the accepted infection rate after surgery. For example, if it is a clean surgery, then the accepted infection rate is should be below 2%. If I am getting 5% wound infection rate, then I have to look and change the way we have been practicing. There could be in many levels. And once we identify the problem and we agree that we need to do the auditing, then we have to agree upon the criteria. How do we define wound infection? What are the things, and what are the things that are considered standard to prevent wound infection? Is the patient getting showered before surgery? Is the patient getting proper cleansing during OR? Are the people doing scrubbing and donning properly? Is there been adequate hand hygiene practices in the ICU or post-operative or in the ward? So many things we have to go for the standard. And then third thing is, now we collect the data. Now we have agreed upon the criteria of wound infection. We have agreed upon the what are the standards that should be practiced to minimize wound infection. Then now we collect the data, which is really the audit per se. We collect data regarding the patients who develop wound infection, and we also collect data on patients who did not develop wound infection also. Then now we identify areas of improvement. Okay, once we collect the data, then we find out exactly what went wrong. So if the patient was not given shower the night before surgery, or there were too many people in the OR, or the preparation antiseptic was not of sufficient strength, or post-operative dressing was not done properly. There are many areas that you can find out. And once you identify the areas of improvement, this is the part, and then that needs correction, and it's a huge boulder as you see on the slide. So then your job is to identify the barriers to change. There will always be some barriers to change. Oh, this happens in this low income country, this always come. And then once you identify the barrier, you need to implement the change. So it could be of the different level. If it is at the individual level, maybe the persons who are involved in the care require further training in skill or infection prevention practice. If your instruments are worn out, you get more complication, then you need to replace the instruments, or you acquire new instrument. And in the team level also, teamwork, if there is a lack of team spirit, then you can have more complication that you can do. Or it can be from the institution level, hospital policy, or hospital's cooperation regarding many things can be instituted. So once you identify areas of improvement, then you make the necessary changes which is, and then you do re-audit. So if you make all the necessary changes and see what is your level of infection now, have you been able to decrease it to less than 2% now? Now if you have decrease it to less than 2%, you have done a good audit, you have made necessary changes to decrease the your rate of infection to the standard, explicit agreed upon standard. So if we talk about surgical or clinical audit, we cannot forget the name of Ms. Florence Nightingale. She is famous for many things, but one thing she is famous for is also in surgical, in clinical audit. She is credited to be the first woman to perform clinical audit during Crimean War in 1853 to 1855. She, along with her team of 38 nurses, performed audit, and she implemented strict sanitary routines and standard of hygiene, and she also made an accurate record of mortality, and she was able to decrease the mortality from 40% down to 2%. Very impressive result. Let's, in one slide, let's briefly define research. I have discussed about the details of research in the introduction of research video, but research as opposed to audit is a systematic process to generate new evidence with the intention to make it generalizable. See the difference of definition between audit and research. This slide briefly describes the differences between audit and research. In audit, care is given based on knowledge gained from research, whereas research tries to create new knowledge, no, not always successful, but the intention is to create new knowledge. Audit measures against the explicit standards which we describe in the explicit criteria, whereas research is done based on research questions and hypotheses. Audit does not involve anything beyond normal clinical care. You do not do anything innovative, innovative in doing audit. Whereas if you are doing research, it may involve, if it is an interventional study, may involve intervention for study purpose on patient. Audit is less rigorous regarding ethical approval, sample size calculation, or analytical statistical method. You do not do all these things while you are doing audit. All you are doing is whether your care is meeting the current standard or not. Whereas in research, the process is much more rigorous. You need mandatory ethical approval prior to the recruitment of the patients. You need ethical sample size based on your research question or hypothesis, and you usually tend to use statistical tests to come to the conclusion. To summarize, periodic clinical audit is a must to make sure that the standard of care has been met. So audit is an orderly and systematic process. A regular audit is the least expensive way to improve the quality of care. So if you are a busy clinician or a basic scientist, nurse, paramedic, you need to do periodic audit to assess whether you are at par with the standard or not. Thank you so much for paying attention to my presentation. I hope to see you in next video. Thank you very much.